Let's talk about organophosphate toxicity. So organophosphates are chemicals that are cholinesterase inhibitors, and because cholinesterase gets rid of acetylcholine, inhibiting this will increase acetylcholine levels at synapses. Symptoms and signs will appear to be consistent with overactivation of the parasympathetic system because this system runs off of acetylcholine more than the sympathetic system does. The chemicals are most commonly found in pesticides and insecticides, and toxicity can come from absorption through the skin, lungs, and GI tract. For clinical features, the onset typically occurs hours to days after exposure. The muscarinic signs can be represented by the mnemonic dumbbells, or defecation, urination, meiosis, bronchospasm and bradycardia, emesis, lacrimation, and salivation. So in essence, liquids come out of every orifice. The nicotinic effects at the neuromuscular junction can cause muscle weakness and fasciculations, and this can include respiratory failure, which is what can lead to the mortality. There are decreased deep tendon reflexes, and symptoms tend to last longer for more lipophilic organophosphates. These lipophilic agents tend to diffuse more into the body, into the fat tissues, and then over time will come back out and continue to cause symptoms. A delayed neuropathy can occur, mostly a motor neuropathy, and that happens weeks after exposure, but not to every agent. For evaluation, organophosphate toxicity is a clinical diagnosis. If it's unclear, a response to atropine can support the diagnosis. A acetylcholinesterase level can be sent, but it may not result quickly enough to be useful. For treatment, altered mental status and impending respiratory failure are indications for intubation. Removal of clothing and irrigation will help to reduce further exposure through the skin. And activated charcoal can be given in the first hour after an ingestion. The two most important medications to know for reversal are atropine and pralidoxime. So atropine is given first. It competes at muscarinic receptors and is administered until respiratory secretions can be cleared and bronchoconstriction stops. However, it does not work at the nicotinic receptors, so what we do is give pralidoxime, which is a cholinesterase reactivating agent. The reason that it is not given before atropine is because sometimes it can worsen the symptoms transiently. So seizures can sometimes happen and are treated with benzodiazepines. For prognosis, the neurologic symptoms typically resolve in a few weeks. However, in the long term, there can sometimes be memory loss and Parkinsonism.